we'll be talking about craniofacial encephalocele updates on management. So a little bit of a background. These are rare but highly debilitating neuroanatomical abnormalities. They can result from herniation of neural tissue through a bony defect and ultimately can lead to death, cognitive delay, seizures, social integration issues. Consensus that proper approach to treating craniofacial encephalocele is confounded by an abundance of surgical techniques and parameters in terms of optimal timing and course of intervention. There is recent evidence that suggests that single and two-staged operations utilizing both neurosurgeons, plastic surgeons, as well as ENT can be successful. The hula procedure and endoscopic endonasal surgery using vascularized nasoseptal flaps have become more minimally invasive and successful compared to larger open techniques. There are still major concerns for consideration, including infection, CSF leaks, craniofacial defects that persist, intercranial pressure increases. There's concern for wound dehiscences, as well as postoperative complications related to frailty. Temporal encephaloceles can be associated with seizures, and these must be carefully monitored, oftentimes requiring additional further surgery. And there are some genetic mutations associated with sonic hedgehog pathway Wnt signaling G protein coupled receptors that we'll go through in terms of predisposition. So here's an evaluation of overall cephaloceles. Can be broken down into more of the occipital versus more of the cranial fault versus anterior. And so this is a good algorithm for looking at where that defect is, whether it's nasofrontal, nasoethmoidal versus spino-orbital, spino-pharyngeal. In terms of the cranial vault, other reasons can be parietal, temporal, fontanelle, anterior or posterior if the patient is younger. The herniation classification can be defined as covering, or if it's not covering, what contacts are involved. So that can be meninges, neural tissue, CSF, leak plus meninges, or meningoceal. You can have herniation of a ventricle, herniation of glial tissue, which is a glial cell, duro plus fibrous tissue, which is a tritic cephalocele. So broadly grouped, the bones can be a distribution. So this is a percentage. You can look at maxilla, orbital, mandibular, frontal, temporal. You can see that the bulk are more occipital compared to more minimal frontal nasal. So these can determine overall timing. Here's Tessier's original design. This is a box osteotomy to really focus on that associated lesion. This often involves some orbital osteotomies. And this is the vascularized nasal septal flap to really show that this pedicled flap, which is critical for closure. Oftentimes you can use some fibrin glue, some packing as well to really help seal that area and prevent CSF leak. In terms of molecular pathways that are involved, sonic hedgehog pathway by far is the most implicated. This can lead to changes in SUFU and GLIFL, ultimately can cause some genetic modulations that predispose. It's really important to have proper measurement of intracranial pressure, both in the pre- and post-operative space. This can really determine the need for further interventions. That's one of the most primary limitations with this type of surgery is continuous CSF leak. So need to have focused monitoring both in the post-operative period as well as when the patient is at rehab. But with successful surgery, these patients typically do